Dr. Akasaka.
Yeah, it's my great honor and pleasure to be here again, and thank you very much for kind invitation. Today's my talk is role of imaging in stent failure. Dr. Patel already showed you some of the important cases yesterday, but I try to add some, right? This is my disclosure. As you know, intravascular imaging should be considered to detect stent-related mechanism problem leading to the stenosis as a class 2A recommendation from the 2018, right? And recently, guideline recommend the clear culprit. We try to use the intravascular imaging and to know how to treat, and also even in non-clear culprit, the class 2B recommendation, but it is very important to know what really happened at the coronary artery culprit. But recent ESC guideline recommend intravascular imaging as a class 1A recommendation to optimize the PCI results. So the intravascular imaging becoming much important compared with previous condition. This is a case with STEMI. The LED total occlusion, and we put a stent, ES stent, and then this is the result, but a little bit is slow flow, but you can identify some haziness in within a stent, and this is a still frame, right? You can identify the lots of protrusion, maybe a thrombus with some plaque, I'm not sure, but and then 13 days after primary PCI, patient yes, complained the chest pain again, and ST elevation could be identified here. Lots of thrombs, and then we did the thrombus aspiration and put a bare metal stent at that time. And then this is the after stent in stent. Still, there are lots of thrombs. I do not know how to treat this correctly, but at the same time, we checked the CYP2C19 genotype, and it's start to poor metabolite. Now, recently, I think that this kind of complication becomes lower than compared with previous condition, because we developed yes, prasugrel or ticagrelor. It might be much more effective, right? And then this is the same case 6 months after PCI. Yes, OCT demonstrate well healing at the site of the stent in stent portion, right? Like this. It's okay. So there are lots of risk of stent thrombosis from the development of the stent, as shown in this slide. There are 3 major causes. Technical portion is the stent itself, and then patient condition, as I told you, the SIP condition, and also procedure-related factor is the main cause of the stent thrombosis. We have to pay attention to the result of PCI by imaging. Yes. Without imaging, we are not sure what really happened within a coronary artery. Therefore, I highly recommend the intracoronary imaging. And also, it might be difficult to predict, but the antithrombotic therapy is very important. This is another STEMI case after, 7 years after DES implantation, after thrombectomy. It looks very nice. What really happened within a stent, I'm sorry, right. Yes, this is an OCT image. You can identify lots of peristrat halo with evagination, right? This is a still frame, lots of evagination and peristrat halo, and the under expansion may be no enlargement of the vessel can be identified. Then we did a bigger balloon, higher pressure inflation to treat this portion. However, 19 months after this treatment, still there are lots of evagination, as shown in this slide. Might be the allergy to the polymer makes this condition, right? And there are another cause of very late stent thrombosis. This is in bare metal stent very late thrombosis. You can identify thin cap fibroadenoma somewhere within a stent, right? And also rupture with thrombus can be identified, as shown in this slide. This is another case of an OCT image of neoatherosclerosis. Here is a thin cap fibroadenoma within neo-intima, and some portion we can identify the rupture of the neo-intima plaque, as shown in this slide. There are lots of causes of stent thrombosis, as you may know, but main mechanism of the stent thrombosis is stent under expansion. Therefore, we have to pay attention to the final result of PCI. And malapposition may cause sometimes an significant plaque at the stent edge. Stent edge character is very important. Not only plaque volume less than 50%, we have to pay attention to the character of the plaque. Lipidic plaque makes an edge stenosis and edge dissection as well, and also the lipid-rich neoatherosclerosis may cause. This slide demonstrates stent thrombosis classification depending on the time of event: acute stent thrombosis, subacute, the late thrombosis, and very late thrombosis. And covered strata are higher in acute and subacute stent thrombosis and gradually decrease according to the time of the event, as shown in this slide. Although the frequency of restenosis and neoatherosclerosis is higher in late stent thrombosis and very late stent thrombosis, therefore the mechanism is completely different between the timing of the instant restenosis. Right? And this is a very important case. Dr. Patel already pay attention to the procedure. Do not do this. All right, you can identify the AL1 to the right coronary, but you can see the deep seating, right? And this is the case with ACS. We put a promus stent in the distal portion and the proximal portion as well, but during the procedure, especially when we take out the balloon, the catheter goes in sometimes, we can identify. Then some irregularity in the proximal portion. Then we did an IVAS first. Here you can identify double layer of the strut here, right? And then absence of strut, the other portion. So I think the guiding catheter makes this dislodgement and also the deformity. Right, this is another explanation, and this is an OCT in the same patient. You can identify double-layered stent and malapposition in the proximal site as well. And this is another case, chronic CCS stent. We did a stent implantation in the mid-LAD. It's a very simple procedure, but during pullback the balloon, we felt the resistance. But at that time, we have to wait the complete disappearance of the balloon deflation. But and also, it might be better to push in the balloon a little bit distal and then check the balloon deflation. But operator aggressively pull back, and then right. It might be very difficult to see the angiography alone, but we try to do the imaging like this, the similar condition. In the distal portion, initially we could see the stent, but no stent here, right? And also here, the single stent layer can be identified, but double stent layer, right? And then here also the disappearance of the stent, that may make sense, the deformity of the stent, right? Therefore, the absence of the stent in the distal portion and the double layer can be identified. There are previously already wrote the data. There are a possibility of the shortening of the stent if you mechanically press the stent. It is very important, and some mechanism of the stent deformity. If you rewire in the beneath of the stent, sometimes makes a stent deformity when you push in the imaging catheter or balloon catheter as well. Therefore, keep the wire until you finish everything, right? It is very important. And this is another case of CCS. You can identify the instantly stenosis here, right? And you can easily identify the tissue growth within a stent. Yes. And then this is an OCT. The very different kind of tissue can be identified. This is a still frame. This is a homogeneous and layered neointima. So it might be very difficult to differentiate clearly the homogeneous, high intensity or a layered or something, right? Sometimes combined as shown in this slide. And then we did an paclitaxel coated balloon inflation because yesterday I already explained the high intensity homogeneous instantly stenosis drug coated balloon, especially paclitaxel coated balloon, is very effective. And this is an after ballooning DCB, right? You can identify some high intensity like this. So this is the instantly stenosis. After the ballooning, you can identify high intensity signal in the intimal site because of the drug-coated balloon makes this drug distribution. You can confirm the success of the DCB in this technique. And also, this already explained by Dr. Patel yesterday. Now, he said from A to F, right? But this is 5, the homogeneous pattern. And there are 2 different types, high intensity and low intensity, and heterogeneous and layered pattern. And yes, and homogeneous pattern as compared with a paclitaxel coated balloon and plain old balloon angioplasty, there are a significant difference. Therefore, the paclitaxel coated balloon is very effective. At the same time, high back scatter, also the paclitaxel coated balloon is very effective. But other type, there are no significant difference. So please do the simple balloon angioplasty to reduce the cost. And this is one of the examples. As I told you, pre-PCI, we can identify a homogeneous high intensity, but stent H, we can layered pattern, and even in the proximal site, we can identify some tissue growth. And then we did a scoring balloon, PCI. You can identify the effect, good result as shown in this slide. And this is a case with a stent fracture. You can identify the fracture of the stent by fluoro, and then we put the stent, right? But at the site of the fracture during pullback, you can identify the absence of strut. But carefully check this condition, right? And tissue growth is mainly around the fracture site, as shown in this slide. So if you have an instantly stenosis, also we have to pay attention to the stent fracture during follow-up. And this is another case after CABG patient had angina, and we put a stent here, but here are lots of instantly stenosis. And also by IVAS shows under expansion. And then we did, this is an OCT image in the same patient. We did a cutting balloon treatment and stent over expansion. And this is a very late stenosis. You can identify calcium within the neointima here, right? And here also, at that time, you have to treat this by IVL recently, but the other way is make an ablation. Otherwise, it might be very difficult to treat completely, right? And there are lots of causes of instantly stenosis, as shown in this slide, H problem and non-overlap stenting, and also there are thrombus extend into the lumen, and under expansion is the very important cause, and stent fracture as well. And this is the data comparison early and late listeners after DES. There are some difference. Lipid routing intima, Tikva-like intima, and intima disruption is frequently in late stent thrombosis and neovascularization as well. And there are some mechanisms already reported. DES, neoarteriosclerosis, very rapid, so accelerated neoarteriosclerosis is the main cause of restenosis compared with bare metal stent. And shown here, this is a landmark analysis. Late stage, there are no significant difference, BMS, DES, and new generation DES, but early stage, there are significant difference as shown in this slide. And this is the prevalence of TLR in case with ACS and CCS during early, late, very late stent stage. Proportion of ACS and CCS increase substantially from early to very late TLR region, and both stent H and non-focal pattern were higher in very late TLR region than in early and late TLR region, although the stent H pattern tend to be more prevalent in CCS than ACS region during early and late period. There are lots of causes, as I already told you, cause of the stenosis, risk factor, anatomical factor, clinical factors, and stent-related factors. And if you identify the mechanism in stent stenosis by the imaging and DES cases, they recommend to do the stent or bare metal drug-coated balloon or IVL as shown in this slide. There are lots of recommendations as shown in this slide. And the final is in the bifurcation lesion treatment. If you leave it alone in the bifurcation site, there are some risk of the stenosis as shown in this slide. How to treat this? If you dilate here, stent move to this portion, it's difficult to decide. Therefore, if possible, there are some possibility to make a good result. I highly recommend to do the kissing balloon at the acute phase. There are some recommendations. Where is the best place to wire? But sometimes difficult. Blind way, we can select the distal portion around 50%. But if you miss to select the distal portion, you can identify the proximal portion wire here using double looming catheter. Crusader, right? If you push in new wire and push in both at the same time, if it is difficult to push in, you succeed to different cell selection by the wire. But if you can easily push in both wire and catheter at the same time, the new wire is in the same cell. You can differentiate, right? But if there are link here, it might be very difficult to treat completely, even if you succeed the distal cell as shown in this slide. So sometimes bifurcation lesion treatment, side branch treatment is focused to discuss, but main branch treatment is very important. Therefore, if there are risk of stent deformity as shown in this slide, you should leave it alone. So OCT is very important to know what really happened within the coronary artery. So there are lots of take-home message to you. But anyway, intravascular imaging should be useful to know the cause of stent thrombosis, and it might be useful to know their cause and to decide how to treat. And I highly recommend to use the intracoronary imaging, especially during PCI, to avoid the late complication. Thank you very much for your kind attention.
Yeah, thank you so much, sir. And in the interest of time, we are winding up the session right now. This particular session, sir. No questions. The next speaker is invited, please.